Welcome to session number 5 in the Clinical Teaching on the Run series. The topic of today's presentation is the direct observation of learners in the clinical setting. Today I will discuss, first, how adults learn clinical skills, and secondly, the principles of direct observation. I will address why we should observe our learners, who to observe, what to observe, and how and when to observe learners. Let us begin with why clinical supervisors should observe their learners. In our last 2 sessions, I presented the steps involved in the clinical reasoning process. The learner often assesses the patient first, then presents the patient's data to the supervisor via the case presentation. The supervisor listens and then asks the learner questions about the patient. Naturally, the quality of the data is dependent on the learner's clinical skills in obtaining this data. Thus, we can see that ultimately the foundation of sound diagnostic reasoning is dependent on sound clinical skills, such as information gathering, clinical examination, and communication skills. But how important are these skills? The history, physical, and lab investigations are all useful in generating diagnoses. It is commonly believed that the history is the most powerful diagnostic tool available to internists, and there is evidence to support this belief. One study investigated the relative importance of each of these factors. It found that the final diagnosis was arrived at by internists 76% of the time after the history, 12% after the physical, and 11% after the lab investigations. The contribution of the history can vary depending on the area of medicine and the type of disease that is being assessed. For example, the history may be helpful in diagnosing cardiovascular diseases, but not as helpful when diagnosing gastrointestinal complaints. Ultimately, once a diagnosis and management plan is identified, the learner will then discuss this plan with the patient. Whether or not the patient will be satisfied with this plan and motivated to adhere to this plan will likely be dependent on the skill of the learner in giving information and discussing the patient's concerns. If the patient does not understand or accept the diagnosis or chooses not to follow the recommendation, it does not matter if you get the right diagnosis. The patient may continue to suffer. A review of the literature in this area reported that the compliance rate of short-term medications was between 70 and 80%, long-term medications 40 and 50%, while the compliance with lifestyle changes was the lowest at 20 to 30%. So clearly, it is not enough to make the right diagnosis or lecture the patient as to what they need to do to get better. We need to observe our learners because clinical skills such as information gathering, physical examination, and communication or counseling skills are the foundation for both sound diagnostic and therapeutic reasoning, and effective patient care is dependent on adherence to these recommendations. So, how do adults develop these foundational clinical skills? I reviewed the learning cycle in session number 1. Here, I will review some key steps. Remember that a novice learns a skill first by watching an expert perform that skill in real time. Naturally, the expert will make the skill look very easy to the learner. The learner may not be aware of what they need to know to perform that skill with ease. The learner at this point is unconsciously incompetent. If the preceptor involves the learner by providing the opportunity for them to practice the skill, the learner may become aware of what they do not know and what they need to know or be able to do to perform the skill. With guidance and information from the preceptor and the opportunity to practice that skill over and over, the learner will become consciously competent. Now, competence is specific to context. So while a learner may be perfectly competent in taking a history from a patient with good communication skills, when they're given a patient with delirium, they may find that they're not able to get the information they need. Competence is specific to context. Thus, one cannot assume that a learner who can perform a skill in one context, for example, intubating a healthy adult undergoing an elective surgery, can perform that same skill in different scenarios, such as different types of patients and or different settings. In fact, we often observe junior residents early in their training when they are involved in fairly straightforward clinical situations. And then we stop observing them as they advance through training and start to face more and more complicated patient scenarios. All learners should be observed in different contexts. In fact, these senior learners would benefit greatly from observation and feedback in these challenging clinical scenarios. By providing them a breadth of clinical experience in their training, hopefully they will eventually be able to master the skill in most of the common clinical scenarios. So direct observation can serve several purposes. First, by observing learners, we can be a more effective clinical teacher and or coach by providing important information for the learner solely for the purpose of improving their clinical skills. Yes, we can observe learners to assess their performance. And finally, we can observe learners to ensure that our patients are receiving appropriate care. In this session, I will be limiting my discussion to the role of direct observation in providing formative feedback. So observation is essential for effective feedback. However, the reality is direct observation of our medical learners in the clinical setting is rare. Performance is inferred rather than observed. One study asked students at the end of their third year of medical school to report. Thus, medical trainees are left to practice on their own. Do they get enough practice to acquire the level of skill they need to be experts or masters in their area? Does practice make perfect? Or perhaps, does practice make mistakes permanent? Perfect practice makes perfect. So the key to successful skill development is not just practice, but deliberate practice. Deliberate practice is characterized by focusing on an aspect of performance, getting feedback immediately after that performance, then having the opportunity to perform the same or similar tasks repeatedly over time. Direct observation has a key role in helping learners to deliberately practice their skills. The first step to incorporating observation in clinical practice is to create a culture in which observation is understood, expected, non-threatening, and routine for everyone. Let us look at these characteristics of deliberate practice more closely. What aspect of performance should the learner focus on? In session 2, we discuss the importance of taking an educational history. It is helpful to ask the learner what he or she feels comfortable and are competent in doing on their own, and what clinical skills or clinical scenarios they feel that they could benefit from some additional guidance or help. We want to focus the learner on practicing their skills in situations where they are challenged. Be specific about what you want the learner to focus on. Rather than observing their history taking, you may want to observe how they use their communication skills to develop rapport with the patient. In particular, you can focus on what they say, how they say it, and their associated body language. You may also want to focus on their charting and/or dictated notes. As part of your educational plan, you will discuss how and when observations will take place. As you will be facilitating the deliberate practice of a specific skill, observations can be brief. It is ideal to observe the learner practicing this skill in different patient scenarios. Sometimes it is easier to pick a specific time or place in which these observations will take place. Perhaps you will choose the first or last patient of the day to observe. There are different methods of observing the learner with the patient. The preceptor can sit in on the encounter, be a fly on the wall, or they can observe indirectly through a two-way mirror or via video recording of the encounter. Finally, the preceptor can record their observations informally by taking notes or use a tool to help guide their observations and take notes. It is important to brief the learner as to how and when you will be observing them so they know what to expect. It is critical to record your observations of the learner performing the skill. One system for doing this is the 4-quadrant system. Start by drawing an X on a sheet of paper. While you're observing the learner with the patient, jot down notes in the appropriate quadrant. The first quadrant refers to start, behaviors that the learner does not demonstrate but should consider starting or adopting in the future. The next quadrant, continue or do more, refers to behaviors that the learner should continue or do more of. Behaviors that the learner should do less are under the do less quadrant, and stop refers to behaviors that were not helpful and the learner should consider stopping. Here's an example of a note taken during an observation of a learner gathering information from a patient. Under the start quadrant, the observer has jotted down that the learner needs to start asking the patient if they have any questions and reviewing the chart before talking to the patient. They should continue or do more eye contact while talking to the patient and do less use of medical jargon. They should stop saying okay every time the patient answers a question or flipping through the patient chart during the interview. There are many direct observation tools that have been developed to assess learners with patients. These tools can help to focus the observer on an aspect of the learner performance and provide a frame of reference for the observer by explicitly listing ideal behaviors. If you're participating in the Fred Bryan's Master Teacher Program, I have added some of these tools in your teacher's toolbox for you to review. So both the learner and the preceptor have an important role in the development of a learner's clinical skills. The preceptor can start by obtaining an educational history from the learner. The preceptor and the learner can develop an educational plan that focuses on an aspect of the learner's clinical performance that would benefit from direct observation and guidance. The preceptor can then observe the learner perform that task and record their observations. In session 6, we will discuss how to teach around that task by providing effective feedback to the learner. Thank you for taking the time to listen to this online presentation. I hope you found it helpful. For more useful teaching resources, please visit our UBC Faculty Development website. Our next session, session number 6, Feedback, is your feedback helping or hurting your learner, will conclude this series.